Assalamu alaikum, everybody. Dr. Noman and Dr. Pulvasha, I hope you both can hear me clearly. If you can, तो chat box में kindly let me know अगर आप लोगों को मेरी आवाज clearly आ रही है या नहीं. All right, we're just going to wait for a couple of minutes, just in case other participants want to join in. So then we'll start the meeting, inshallah.
Start video.
All right, I have it's 5 minutes past 4, so I guess nobody else will be joining in. So हम start कर लेते हैं. Just give me a minute.
Fahad Dazi Mohmera.
All right, actually.
Sorry.
No problem.
It's okay. Thank you.
All right. Sure. And one participant just messaged उनकी, I think unfortunately light चली गई है. So just waiting for them कि वो rejoin कर पाती हैं. अच्छा, right, she's here. चलें ठीक. All right. Assalamu alaikum, everybody, and I welcome you all to the second batch of the maxillofacial radiology course, in which we'll be focusing on the extraoral radiographs. What are the techniques? What is the anatomy that you see on those radiographs, and their interpretation, inshallah, which will be done in the final session. So today we're just going to be discussing some of the techniques and anatomy that you see on midface X-rays. And what I've decided to do is that X-ray guidelines जो होती हैं on which X-rays you're supposed to advise in for mid-face and mandibular trauma. So I'm going to be doing those side by side. I thought end में शायद it will become just too much to do in the last session. So today when we're going to be discussing mid-face X-rays, we're going to be discussing some guidelines as well. So I hope you find that illuminating as I did. So as you guys know, the X-rays that I already advertised, that these are the X-rays I'll be teaching you. Not all of these X-rays are X-rays that you'll be seeing routinely in your practice or in your exam, but depending on where you work, sometimes you won't have access to the gold standard X-rays like CT or OPG. If you're working in the periphery somewhere, so probably you'll have to make do with these plain X-rays, which may or may not be in the digital format, so they may or may not be very clear, but still it will be what you have. And if it is possible for you to make a diagnosis or a treatment plan based on these X-rays, again depending on facilities where you are working. So if you're aware of the anatomy and how to interpret these X-rays, so maybe you can use them for diagnosis and treatment planning purposes. So today we'll be discussing the mid-face X-rays. We'll be discussing the standard OM 0-degree occipitomental view, 30-degree occipitomental view, a Waters and a Caldwell view. We'll also be discussing true lateral skull submentovertex. These will be primarily the X-rays that we're going to be discussing today. So let's start with the standard 0-degree OM view. So as you know, this is the session which is dedicated to mid-face X-rays. So the standard OM view, which stands for occipitomental, is basically for the facial skeleton and for the maxillary sinus. So the way this X-ray is taken is that basically the patient is asked to sort of tilt their head upwards. So what it does is that the dense bones that are present in the base of the skull, the mastoid and the other area, occipital bones, those are a lot denser compared to your anteriorly placed bones, which are a lot thinner and less dense. So when you tilt your head upwards, you can sense that your mastoid and your base of skull is going downwards, and the anterior part of your face that is going upwards. When it goes upwards, basically when the X-ray beam has to pass, it won't pass through that dense area of the base of the skull, and it will be allowed to focus almost purely through the anterior part of your face. And you know that whichever portion of the face is closest to the X-ray, that will come out clearly in the X-ray film. So this allows you to see the anterior part of the face quite well as compared to the posterior part. So what is it indicated for? It's indicated for all of your mid-face and upper face trauma like Leaford 1, 2, 3, zygomatic complex, NOE fractures, orbital blowout, coronoid fractures, investigation of the maxillary antra, investigation of the frontal and ethmoid sinuses, and investigation of the sphenoidal sinuses. However, you should know that other than the frontal and maxillary sinus, the other sinuses, the sphenoid and the ethmoid, are sinuses that you will not see very clearly on this X-ray. So, are the rest of the participants also having the same issue? You can't see the slides that I'm sharing?
Ji sir, I can see the only first slide.
See the first slide?
Yeah.
Hang on, let me see. Sure. Can you check now?
Yes sir.
अभी ठीक हो गया?
Yes sir, अभी सही है. Yes. Yes sir, अभी सही हो.
All right, चलें. Now can you see this indications वाली slide भी नजर आ रही है आप सबको?
अब नजर आ रही है, पहले नहीं थी.
नजर आ रही है. अच्छा. Very sorry, I don't know why that happened. Anyhow, All right. So this is, let me just go back to the 0-degree view. This is the 0-degree view, and just showing you a picture of it. बाकी तो चीजें मैंने आपको verbally उस पे वो बता दी थी. But here we'll compare it with the rest of the X-rays, and maybe then you can have a much better idea of how to differentiate between a 0-degree view and the other views. So these were the indications. I'll just go through them again quickly. You have all the midface trauma, leaf port 1, 2, 3, zygomatic complex, NOE fractures, orbital blowout fractures, coronoid fractures, investigation of the maxillary antrum, and investigation of the frontal ethmoid and sphenoidal sinuses. All right. So these are the gross indications. So how is this X-ray taken? I know it is called a 0-degree view, but here you will note that this 0-degree is basically sort of a misnomer in a way, because you can see that the patient has tilted their face upwards. And how much of a tilt are we looking for? Basically, this tilt, if you can see this line over here, this canto-meatal line, this because it's made up from the lateral canthus all the way to your external auditory meatus. So we make a line, this is an imaginary line over here, and the X-ray beam in a way makes about 45-degree angle between the this line and the X-ray film. So you have basically have a 45-degree tilt over here. This is the angle that is made, and the X-ray beam is focused as fired as if you are as if it's through the body of the zygoma. All right. So almost the inferior surface of the body of the zygoma is where the X-ray beam is fired at, and the patient's head is made at an angle of 45 degrees with the X-ray film. And the standard line that we use is this canto-meatal line. In some places, you can also see it mentioned as OML, which is orbitomeatal line. So you can also call it that as the orbitomeatal line. So this orbitomeatal line has to make a 45-degree angle with the X-ray film. This is the X-ray film over here. And you fire the X-ray through the body of the zygoma, specifically maybe through its lower or inferior surface. So this is the standard way in which you take this radiograph. So what is the anatomy that you will see? Well, you won't see everything very clearly, but the big things that you are supposed to see on this is the frontal sinus over here, which you can appreciate as two radiopacities which are lying above this nasal cavity. You will see inside this nasal cavity, you have a nasal septum over here, which is obviously radiopaque. This is the nasal cavity over here. Here is the lateral margin of the orbit, which we also refer to as the FZ or the frontozygomatic area. You also have the posterior margin of the anterior cranial fossa, but again, I would suggest that you just stick to interpreting the anterior parts of the face instead of focusing on the cranium in this, because it's not a very clear area for you to see. Anyhow, here you also have the coronoid process over here, and here is the condyle. This is the zygomatic arch over here. Again, you have the lower border of the mandible, which you can see over here. If you look very closely, again, you might be able to see the vomer, and behind the vomer, which is lying actually behind the vomer, in this X-ray, it'll look like you can also see the sphenoid sinus. But like I said, since the sphenoid sinus is covered anteriorly here by the teeth, you probably won't be able to see the sphenoid sinus very well. So over here on the lateral aspect of the nasal cavity, here you will see the maxillary antrum. And if you have a very keen eyes, you might be able to see the infraorbital foramen over here. But like I said, the main structures that you can maybe interpret clearly on such an X-ray would be the frontal sinus, the lateral margin of the orbit, the zygomatic arch, the coronoid, lower border of the mandible, and the maxillary antrum over here, as well as the nasal septum. So the other structures, I would suggest don't try to comment on that, because you won't be able to see them very clearly on such an X-ray. All right. So let's go on to the second X-ray. Now you will be able to note the second X-ray is called a 30-degree OM view. And this looks quite familiar, quite similar to a 0-degree view. But if you look more closely, you will be able to see that the patient's head is tilted even further upwards. All right. If you compare it with this one, and you compare this one, so you can appreciate the difference between the two. That this X-ray, the 0-degree view, in which the patient head appears to be slightly upwards, but in the second X-ray, the patient head appears to be tilted even more further backwards. And in this, you can see the frontal sinuses are appearing very large as compared to this X-ray over here. See, in this, you could see the frontal sinuses as quite small, but in this X-ray, these frontal sinuses look quite large. All right. So why do we do a 30-degree OM view when you already have studied a 0-degree OM view? Well, it enables the detection of bony displacement if present, especially if it is done in conjunction with a 0-degree view. So if you've done a 0-degree view and you are not sure if there is a fracture there or not, so we usually order a second X-ray, which is this 30-degree OM view. So this can help tell you if a fracture is present or not, and if the fracture which was present in the 0-degree view, is it displaced or not? That you can tell by the 30-degree OM view. So 0 and 30-degree views are usually done in conjunction with each other. And in here, if you can pay a little bit of attention here, if you observe keenly, this radiopacity over here, circular one, which you see at the inferior orbital rim over here, and this one over here, this is the infraorbital foramen. All right. This is usually commonly misdiagnosed as a fracture of the infraorbital rim, but this is not actually a fracture. This is the inferior orbital foramen. All right. So the rest of the anatomy is quite similar to a 30-degree view. Right. We have a question over here. What is the patient position in 30-degree? I'm coming to that, Dr. Nawan. In the next slide, hopefully you'll be able to see it after I've done the indications. All right. So here is the patient position for the 30-degree view. As you can see, it is similar to the 0-degree view that you just saw. The patient's head position is the same. The orbitomeatal line has to make a 45-degree angle with the film. But if you notice now in the 0-degree view, if you look at my cursor, at the 0-degree view, the X-ray beam was focused over here. All right, it was placed over here. So this was the 0-degree view. But now that now you have taken the X-ray beam cranially, it has gone upwards. So it is making a 30-degree angle over here. And what line is this? Well, this is passing between the superior border of the external auditory meatus. It is following almost, you can say, the sigmoid notch, and it is passing occlusally. All right. So it makes almost a 30-degree angle over here. With this line. So this is why this is called a 30-degree OM view. In the first one, in the 0-degree one, the X-ray beam was over here, so it was making no angle with this line. So when it was making no angle with this line, that's why it was called a 0-degree view. But now that you've taken the X-ray tube upwards, we take it upwards by almost 30 degree. So now that is why this is called as a 30-degree OM view. Again, you should appreciate the fact that here since we've taken the X-ray beam upwards, we are avoiding the superimposition of all the dense bones of the skull which are present over here. So in this way, we can see quite clearly what the anterior part of the face would look like clearly, and we are avoiding the superimposition of the structures which are present at the base of the skull over here. All right. Okay. So you can, if you're getting confused by this orbital occlusal, this meatal occlusal line, you can just consider it as somewhat as a line parallel to the floor. All right. So a line which is parallel to the floor on which the patient is standing on, you can just use that as a landmark instead of this maybe confusing line. You'll be wondering how do we ensure that this X-ray beam is passing through the top of the meatus and sort of interocclusally in the incisor area. So just consider this as the line which is parallel to the floor on which the patient is standing, right? Okay, so what are its indications? Its indications are quite similar to that of the 0-degree view. You have Lefort 1, Lefort 2, Lefort 3 fractures and the coronoid fractures. But if you paid attention over here, in fact, let me just take you to the previous slide. In this, you can't, other than the maxillary antrum, you can't see the orbits very clearly in this, all right? You can't see the mandible very clearly in this. You may be able to see the coronoids somewhat, but again, maybe clearly, maybe not clearly enough. So that is why we are doing this X-ray in conjunction with the 0-degree view, all right? So, and I'm going to be talking more about trauma-related indications because for any pathology-related investigations, extraoral radiographs are usually not done anymore, all right? So again, let's come to the anatomy and similar anatomy like the one you saw in the 0-degree view. You have the frontal sinus over here. You can see the orbit, but you can't really see too much of the medial orbit, medial orbital wall. All right. Other than that, here you can see the maxillary antrum, the infraorbital foramen. I already showed it to you in the on the first slide. You can see the zygomatic arch quite clearly, but other than the coronoid, you might be able to see the condyle. But look at this area over here. This is just, you know, a huge white blob. Basically, you can't really make out what structures are present here. So because the X-ray has been fired actually some through this area over here. So you won't see the mandible very clearly in the 30-degree view. And this is again another clue in case you are confused about whether you're looking at a 30-degree view or a 0-degree view. So in the 0-degree view, you will be able to see the mandible quite much better than this. But as compared to a 30-degree view, you won't be able to see the mandible or the anterior teeth quite clearly at all. You can see maybe a hint of the mastoid process over here, but again, not too clearly. Nasal septum, nasal cavity over here, infraorbital foramen already we've talked about, and the lateral wall of the orbit or the FZ area, which you can see quite clearly in this. So here is an illustrated diagram of the anatomy that you can see. Again, nothing much that has been added over here, but just in case if you're finding that real X-ray anatomy to be quite confusing, so I've put in an illustrated diagram here as well. So you can see the frontal sinus over here. You have the nasal bone over here. And again, anterior ethmoid sinus will not be very clear since you can't see the medial orbital part in this X-ray very clearly. Number 4 here is your orbit. Number 5 is your nasal septum. Greater wing of the sphenoid, they say you can see it, but again, it's quite difficult to see unless you have a really good quality digital X-ray, which in most of our peripheries, you won't have a digital X-ray probably available. So just focus on the anterior parts of the face, which you need to make your diagnosis for trauma purposes. All right. So same things over here. Now I'm not really going to go through all of them one by one, but just here for illustration purposes. All right. Now, this is an X-ray that we commonly used to see in our patients that used to be brought to my center. I work at Khyber College of Dentistry. So most of the patients from the periphery used to bring this X-ray with them. And I used to think this was just a very odd sort of or a poorly taken Waters view. But it turns out it was actually a Caldwell projection. And this is a projection which is actually done for the frontal sinuses. And that is usually done by our colleagues in the neurosurgery department or someone who's working in the periphery in an emergency in the ER area. So they usually order the Caldwell projection just to see the frontal bone and the frontal sinuses. So you can see the frontal sinuses are quite clear in this X-ray over here. But for mandibular trauma purposes, you can see you really cannot make out too much of the mandible in this case. So it's basically a caudally angled radiograph. It means it's pointed downwards with its PA projection. One common question which is usually asked, and I thought I'll share it with you guys, that why are most of the maxillofacial radiographs always taken posteriorly? Like, why is every X-ray you order, it is usually PA skull or PA mandible or even PNS? Why are all the X-rays taken in this direction? Well, the reason is that if you put the X-ray beam in front of the face, so then the eyes and the orbit are getting a lot of radiation. So we basically don't want to cause radiation-induced damage to the eyes. All right. So that's why in all the cases that you will see, the X-ray has to be taken from posterior so that a minimum amount of radiation is actually transferred to the eyes. All right. So this view is usually used in imaging of the skull or facial bones, depending on the clinical indications. But the most major indication of the caudal projection is for viewing the frontal sinuses. So what is it indicated? It aids in visualizing the paranasal sinuses, especially the frontal sinus. It can help to assess 4 inflammatory conditions such as sinusitis, secondary osteomyelitis, and sinus polyps or cysts. Additionally, any fractures to the orbit may also be determined through this view. So frontal bone and orbital fracture, you can somewhat visualize them from this caudal projection. So how is this taken? Well, now can you see the difference between this and the other views? In the other occipitomental projections, the patient's head was tilted upwards. All right. But in this case, in the caudal projection, the patient's head is now tilted downwards. All right. So when the patient's head is tilted downwards, such that only the forehead and the nasal tip is in contact with the film, the rest of the face is not in contact with the film. So a 15-degree angle is made with the floor, and the X-ray beam is then fired through the orbits and through the nasal bone. All right. So when it is fired through this area, you obviously will see the frontal sinuses and the orbits quite clearly, but the rest of the facial skeleton, you won't be able to see it very clearly. All right. So the caudal projection is basically a 15-degree caudally inclinated occipitomental view. All right. So now coming to the view that we usually order whenever we come across a patient with mid-face trauma, and that is the Waters view. And the Waters view is basically a 37-degree OM projection. All right. So which projections we've studied so far? We've studied a 0-degree OM projection, which is done in conjunction with the 30-degree OM projection. All right. So 0-degree, 30-degree, and a 15-degree projection. And now we are studying a 37-degree OM projection. All right. So this is done for evaluation of the sinuses, again, mid-facial bones and the orbit. One thing you should obviously know, some of you are somewhat new TMOs, junior TMOs. So you should know that all OM projections have now been replaced by CT scans. CT is considered to be the gold standard for evaluating mid-face trauma. But obviously, due to patient finances, it may not be possible for you to order a CT for every patient who has a mid-face trauma. So you might have to rely on these X-rays in order to make your diagnosis. But still, for this reason, I'm telling you which X-rays will be most beneficial to you in order to catch a fracture and make your diagnosis. All right, so you can see this is the patient positioning for an occipitomental projection. It is similar to the one that was taken for the 0 and 30-degree OM projection. The only difference here now will be that the X-ray beam, which is located over here, that will be making a 37-degree angulation with the floor. All right, so instead of 30, now it's changed upwards by another 7 degrees. So now it's a 37-degree OM projection. and that is how this X-ray will be taken. So you can see the difference between the Caldwell and the Waters view. In the Caldwell projection, the patient's head and the anterior bridge of the nose, that is placed on the X-ray film. But for other occipitomental projections like the 0, 30 and 37, in these only the chin of the patient is placed on the X-ray film. So what is the anatomy that you see? Again, similar to the anatomy that you will see on the 30-degree and the 0-degree OM projection. Here you have the frontal sinuses. If you look very closely over here, you might be able to make out the supraorbital canal. You have the zygomatico-frontal suture over here. Again, infraorbital foramen over here. I won't get into the orbital fissures or the foramen rotundum base of skull anatomy in such films, so kindly try to avoid those and avoid commenting on those if possible. You can see the coronoid process over here, condyle over here. This is the zygomatic arch, also called as the zygomatico-temporal suture. This is the body of the zygoma. This is the zygomatico-maxillary buttress over here, which you can see as quite a thick line. This is the maxillary sinus over here. All right, and what else can we see? Yeah, that's about it. So anatomy is quite similar to what you see on a 0 and 30-degree, but again, there are varying degrees of how clearly you can see those structures over here. All right. Okay. Now, interpreting these, this Waters view is very essential because it has specific lines and curves that you are expected to know. The lines that you are seeing over here, these are called Campbell's lines, all right? So you are supposed to, whenever you have a Waters view put in front of you, you are supposed to be commenting on these lines that what do you see on line 1, 2, 3, 4, and 5. You don't see the line 5 over here, but line 5 is made up of a line which passes along the inferior border of the mandible. And this was put in by a surgeon who goes by the name of Trapnell. Okay? T-R-A-P-N-E-L-L, Trapnell. So 4 lines are of Campbell and the 5th line is by Trapnell. So line 1, it basically passes from the temporal bone on the side and passes from the superior orbital rim, frontal sinuses, and the superior orbital rim on the other side to the temporal bone on the opposite side. So this is line 1. Line 2 passes through the zygomatic arch, through the body of zygoma, inferior orbital rim, nasal septum, and the corresponding structures on the other side. Line 3 passes through the condyle, the coronoid, the zygomatico-maxillary buttress, the anterior nasal spine over here, and the other corresponding structures on this side. Line 4 passes through the occlusal plane between the maxillary and mandibular teeth, and line 5 passes through the inferior border of the mandible. So whenever you are asked to interpret a 37-degree view or a Waters view, so you should be using this terminology that I see, let's suppose, discontinuity in line 1, or I see discontinuity in line 2 at let's suppose, inferior orbital rim, unilaterally or bilaterally. Line 3 and line 4 appears to be intact. You know, so just making up a make-believe scenario here. That is how you're supposed to present these Campbell's lines. Other than the Campbell's lines, there are also another secondary curves which are not very clear over here. So I've just put in a separate side over here. This is just the interpretation of the Campbell's lines, which I've just already explained to you. So you can go through this when I share the video, inshallah. So you have some secondary curves which are called DOLAN lines. The full name is DOLAN and JACOBY'S lines, and these lines are also called as elephant head lines. You can see the zygoma sort of makes up a very cute elephant. So this is called the elephant head interpretation as well. So line 1 is basically the orbital line, so in which you have to look at the whole orbit. All right. So line 1 is the orbital line. Line 2 is the zygomatic line. As you can see, it passes from the FZ suture to the superior border of the zygomatic arch. All right. Line 3 passes through the inferior border of the zygomatic arch and the inferior body of the zygoma, as well as the maxillary sinus or the zygomatico-maxillary buttress over here. This is line 3. And in some books, the nasal cavity is designated as donal line 4. All right. So whenever you're interpreting the Waters view, you have to interpret it in terms of the Campbell lines as well as the Dolan and JACOBY'S lines. All right. And Dolan and JACOBY'S lines are also called elephant head lines. All right. Okay. So then coming to another view, which is called the submentovertex view, which is quite rarely done. But anyhow, it's still a very useful view. It basically shows you the base of the skull, the sphenoid sinuses, and the facial skeleton from below. All right. So it is usually used for investigation of the sphenoid sinuses, but in trauma purposes, we use it for investigating the fractures of the zygomatic arch and its displacement. All right. It can also be used. It used to be used for assessment of the thickness of the posterior part of the mandible. As you can see, you can quite clearly see the posterior part of the mandible over here. So before the osteotomy, they used to figure out the length, the thickness of the mandible beforehand using a submentovertex view. But obviously nowadays, with the use of CBCT, this is no longer done. So fractures of the zygomatic arches is its main indication for our purposes. It shows us the thin bones of the zygomatico and temporal bone over here. Because these are very thin bones, so for this, it is a requirement that we don't use the X-ray at its full power. This is called underexposure. If you have an underexposed X-ray, what that will do is that these thin bones will appear bright on that, and this rest of this will appear extremely white. But if you overexpose this X-ray, then you won't be able to see these thin bones because they're not able to absorb. They're not able to absorb all of the X-ray beam, and then this area will just appear black on an overexposed X-ray. All right. So let me just show you an example of an underexposed X-ray. So as you can see, these are very thin bones. All right. So when we have decreased the power of the X-ray, so then we can see these bones quite clearly. But since we haven't given the X-ray beam a lot of power, so we can't visualize this dense area over here, and this is just appearing like a huge white blob. All right. Okay. Okay, so we have less than a minute in this meeting. So if it just finishes, so I'll just leave it at this slide over here. I'm going to restart the meeting in just a minute. So if it finishes, just don't be alarmed and rejoin it with the link that I've already provided. Right. So let me just stop it here and I'll restart it at this slide.